Good morning, everybody. We are at TCT in Boston, and we are very excited to have this great presentation in the morning at 8 o'clock. Good morning to everybody. And we have a very nice presentation on the mitral regurgitation treatment with the Carillon device. And we have here to introduce our session, Dr. Marty Leon, to start with, and I have my co-moderator, Klaus Witte, with me. I am Samir Kapadia from Cleveland Clinic, and Dr. Leon will introduce the session to us.
Samir, thank you very much. Well, first, welcome to TCT. It's great to have you all here. I think one of the strengths of TCT is the ability to be able to feature and do deep dives into new technologies. Now, the Carillon device is not what I would consider to be a new device, but the technology genre and the way it's being used is very refreshing, very new, and in fact quite innovative. Now, we've learned over the past decade, and you learn by doing various clinical trials, by looking at data very carefully, that the relationship between mitral regurgitation and LV function is intimately connected. And especially when we're talking about functional or secondary mitral regurgitation, it's impossible to separate the two. And it's become clear that although we develop devices that may have an effect directly on reducing mitral regurgitation, they may have more or less effect on improving LV functioning, remodeling the left ventricle, preventing progression of LV dysfunction, and really treating the patient's underlying disease, which is HFrEF, heart failure and reduced ejection fraction. So this is an interesting situation where a device, the Carillon device, which is thought of as being an indirect angioplasty device in the mitral space, is now being not repurposed, but reapplied to a population of patients that don't have critical mitral regurgitation, where the primary goal is to markedly reduce or eliminate the MR, but they have LV dysfunction, they have HFrEF, they have symptoms of heart failure, where the device, by other means, may have a beneficial effect on improving their heart failure. And that's the concept that we're going to be talking about. You're going to be hearing a lot about the technology itself. You'll see some of the earlier clinical results, some hypotheses on why it may be effective, and you'll also hear the specifics of a critical, pivotal clinical trial that is being conducted right now in the United States, the Empower trial, that should really test this concept of whether or not an indirect annuloplasty device can result in some basal ventriculoplasty effect that might improve patients that have heart failure, possibly some degree of mitral regurgitation, but the primary treatment target is to treat and improve heart failure. So I'm excited about where this technology is now going. It can be used by itself, or it can be used in combination with other devices in sequence. And I think that this next several lectures and this ensuing hour, I think, is going to educate all of us on some of the latest directions for the Carillon Mitral Contour System. Thanks, Samir.
Thank you, Dr. Leon. It's very insightful. And as I said, and as Dr. Leon pointed out, although this is an older device, the trial and the hypothesis, how we are going to explore the mechanism of action as well as the benefit in the heart failure treatment, is brand new. So with that in mind, we are going to start first with the first talk with Dr. Dib. He is going to present to us the annular reduction therapy for heart failure with the Carillon system.
Good morning, ladies and gentlemen, and I will be talking about the Carillon device for the treatment of patients with heart failure and mitral regurgitation. I have nothing to disclose regarding this talk. I'll be addressing the following topics: the unmet needs, the Carillon system and the procedure, summarize the early studies, an introduction of the pivotal trial, the EMPOWER trial. As per the American Heart Association, the prevalence of heart failure is 6.2 million patients suffer of heart failure in the United States alone. And 30 to 50% of those patients have functional mitral regurgitation. Survival is reduced, even if the mitral regurgitation is mild. One might think that there is the functional or the FMR is part of vicious cycle, as you just heard in the introduction from Dr. Leon. Left ventricular dysfunction can lead to secondary mitral regurgitation, and secondary mitral regurgitation can worsen left ventricular dysfunction, and so forth, and we end up with heart failure. And the question is, would treating mitral regurgitation early interrupt this vicious cycle? And as you know, many of the clinical trial and devices has been used so far is use a device for patients with severe mitral regurgitation. If we look at the co-opted trial, the applicability, 3.7% of patients with heart failure and functional mitral regurgitation. Currently, we treat patients with heart failure obviously with medication, with all spectrum of mitral regurgitation, and interventional therapy, whether percutaneous or surgicals, applied on MR3 and 4, severe mitral regurgitation. What if we have a low-risk procedure and simple device to use? Would we use it early for mitral regurgitation? Here's the Carillon system. It's made of nitinol with 2 anchor, distal and the proximal. The distal anchor placed in the great cardiac vein and the proximal in the coronary sinus. And as you see here is a simple procedure. You can go through the jugular vein, take angiography of the coronary sinus, place the appropriate device, cinch, anchor, and reshape, and bring the two leaflets together to reduce the mitral regurgitation. You can imagine this is a 10 French system, but you can imagine you don't need a general anesthesia, you don't need a transeptal, and rarely you need a transesophageal echo. It is simple to use device and fully recapturable device. We heard from before philosopher Leonardo da Vinci said simplicity is the ultimate sophistication. The early study that has been done using the Carillon device, probably you remember them, the Amadeus Titan, Titan II, and Reduce FMR. Approximately 300 patients were involved in the evaluation of this technology. And I'm going to present the pool analysis of those patients from the clinical trial that has been done. What we noticed, very impressive safety as a first and most important part of evaluation a device. 98.9% freedom from device-related major adverse event at 30 days. High safety profile. And even when the therapy applied in mild and moderate mitral regurgitation, you do see favorable outcome in terms of remodeling and in terms of a clinical endpoint. Reduction in left ventricular in diastolic and systolic volume, improvement in New York Heart Association class, KCCQ, and the 6-minute walk test. We know well from the randomized clinical trial, there's strong correlation between remodeling and mortality. The larger the ventricle, the higher the mortality. And when we look at the data from the clinical trials, comparing the Carillon device with other therapy, whether drugs or devices, we do see a favorable effect in terms of remodeling. Currently, the the European guideline placed the device as a 2B recommendations. And if we just look at the 77 patients from Reduce MR who meet the criteria of the EMPOWER trial, inclusion and exclusion, we do see, again, significant remodeling, and we do see significant improvement in a clinical endpoint. And that's why we are very excited about this pivotal trial that might change the way that we treat patients with heart failure and functional mitral regurgitation. In summary, the Carillon device has the potential to be the frontline interventional therapy for heart failure with functional mitral regurgitation. Excellent safety profile, device designed for a simple and effective procedure, and allow for all sequential therapy as needed. Currently in the EU, and 1,700 patients has been implanted. Thank you for listening.
Thank you. Thank you. It was a great presentation. Maybe we have a few minutes for the questions. So, Dr. Leon, the first question I wanted to just ask you is that we are moving towards early treatment, say, in aortic stenosis. This is probably the first time where we can explore early treatment for mitral regurgitation in functional MR. Is this the paradigm-changing approach for the treatment?
Well, Samir, that's a great question. I strongly believe that we treat patients too late, and when we wait for ultimate clinical expression and severe LV dysfunction, at times we've reached an irreversible stage of treatment. So the idea of what we've been calling preemptive treatment in patients that have a pathobiologic substrate that can be altered, that modifies the natural history of a disease, to me that makes perfect sense. An example of that in the surgical world is many times they'll put a ring or on the tricuspid side, well before anybody has any symptoms, with the understanding that what they're doing is really changing the natural history, and that's been proven to be clinically very successful. Now, the downside of that is that many of these patients aren't as symptomatic. Sometimes it takes longer to demonstrate clinical benefit when you treat earlier. So there's a little bit of a positive and negative when you treat early in terms of clinical trials. But the idea of doing this earlier in the disease process makes perfect sense. And what I like about this device, first of all, it's not really in the cardiac contours. It's really, to a certain extent, is extra cardiac. It's an indirect annuloplasty that favors the atrial side. So it doesn't obviate any other therapies you might consider doing in that patient at any point in time in the future. So it has that virtue as well.
Wonderful. Klaus, you treat a lot of patients with heart failure. What do you think is how do you see this therapy in relation to other medical therapies that we have?
It's a good question, and Marty has already started the discussion around early treatment in patients with heart failure. Those of us with more grey hair than others will remember the times when we used ACE inhibitors in people with severe heart failure in consensus study. And then over the course of time, ACE inhibitors moved into patients with less severe heart failure, and then eventually into people who just had a heart attack and might get heart failure. And so I think this is because of the safety profile of this device, and I'll show you some more safety evidence in a moment. Because it's so safe, you can use it in patients earlier in the course of the disease, and you can also use it in patients with multiple morbidities without worrying about the need for a general anesthetic and transeptal punctures and other bits and pieces that are required. But in addition to that, as we've heard, it doesn't stop you moving on. So should the disease progress, you can then use other therapies as they become indicated. But as Marty touched on, which I think is a really important point, is disease progression modification or modification of the disease progression is incredibly difficult to describe, particularly in observational studies, because you don't know where the patient would have been had you not treated them. So the only way really to do this is to start early on and to wait a long time. And we did the same with CRT, didn't we? We had the CARE-HF study, class 3, class 4 patients, relatively short follow-up, and then we moved from there into reverse with a much longer follow-up required to show the long-term benefits of treating dysynchrony early. And I think you're absolutely right. We're at a stage where we're looking at treating mitral regurgitation and perhaps even simply annular dilatation much earlier before they even get severe MR to delay the progression of the condition.
No, that's wonderful. I think this takes us to very nicely to the next talk that you are going to give on the CINCH-FMR post-market registry results. This is the first time that we are seeing these results, so thank you for bringing this to the TCT.
Well, thank you very much for having me. It's an absolute delight to be here, and thank you all for coming along today and for joining on the internet. I know I've got colleagues in Aachen who are listening intently to the results of the registry which we participate in. These are the interim results of the CINCH-FMR post-market registry and the long-term aim to describe the use of the Carillon device in day-to-day practice and the benefits and safety and efficacy of doing so. These are my conflicts of interest. So we've heard about the studies that have already been completed. And in fact, it was 4 years ago that we presented the results of the first randomized, sham-controlled, double-blind study of a device in this space, the Carillon device, showing that this percutaneous, entirely transvenous approach can reduce mitral regurgitation and benefit left ventricular remodeling. The CINCH-FMR registry will build on this. It's going to be a multi-center, real-world study of patients treated with the Carillon device as part of standard of care. And it will recruit at least 150 patients in Germany in up to 40 centers. Now, retrospective enrollment is allowed, but only if we have a complete data set at baseline. And patients will be invited to provide informed consent to allow us full access to patient records and also coordinate the follow-up procedures. The first inclusion was from June 2017. The planned outcomes will go out through to 5 years, so all patients will be followed for at least 5 years. And there'll be 3 key issues. The first is safety. The second is clinical efficacy, and the third is mechanistic efficacy. And I'm going to show you today an interim analysis of 101 patients with up to 5 years of follow-up. These are the patient demographics at baseline. You can see it's an old collective. These patients are mid-70s. They have the standard constellation of cardiovascular comorbidities, and a large proportion have left ventricular systolic dysfunction with an ejection fraction of under 50%. What you'll also notice is that the vast majority have quite severe symptoms of heart failure and also have at least moderate to severe mitral regurgitation. These are the baseline medications, and as you would hopefully expect nowadays, given the population has a large proportion of patients with left ventricular systolic dysfunction, that we're dealing with a population that are well managed according to the 4 pillars of heart failure therapy, with a combination of 4 different agents in a large proportion of patients. And this is how the follow-up is progressing. You'll see these are 101 patients that we currently have enrolled. And over the course of the next years, not only will enrollment ramp up, but of course we'll work through the follow-up periods and comprehensively collect the data at each time point to allow a more complete picture of where things are going. So let's deal with safety first of all, because I think that's really important. If we're dealing with an old group of patients with comorbidities, possibly with less severe mitral regurgitation, we need a device that's relatively easy, but also incredibly safe. What we can't be doing here is taking people who have mild symptoms or mild mitral regurgitation and use something that we think is preventative, but that has complication rates. So you'll see from these data, yes, these are old patients. They obviously have adverse events, which includes all-cause hospitalization, all-cause mortality. But if you look at the device and the procedure-related adverse event rates, you'll see they're incredibly small. There are no device-related events and only 2 procedure-related events, both related to access problems. So it's safe, but does it work? Well, here are the data looking specifically at something that really matters to our patients. How are their symptoms? And this is actually of key interest to us. We want to help our patients, and we want them to feel better. And you'll see that the device absolutely improves NYHA class over the course of time, and that this improvement is persistent through to 5 years. Equally, the device does what it says on the tin. It reduces mitral regurgitation. Now, we know this from the randomized controlled studies, but it's nice to see it here in a real-life constellation with a nice improvement at 1 month, ongoing improvements out to 1 year, and then maintenance out to 5 years. So how does this look in terms of survival? Well, the data for survival in an observational study are obviously a little difficult to put into context sometimes, but the survival curve in the CINCH registry is similar to the data that we just heard in the pooled analysis that was published a couple of years ago. But with one additional interesting question, there is this prolonged period of stability out to 3 years that really does need more investigation. So in order to put this into a bit more context for you, I want to show you the data from Biostat, which were published just this year. Biostat was an observational cohort study in people who either had a very high BNP or evidence of left ventricular systolic dysfunction, but both groups had to be on at least 40 milligrams of furosemide. Of the 2,500 patients enrolled into Biostat, over 1,000 had moderate to severe mitral regurgitation at baseline. So what the investigators did was they created a landmark point at 9 months where these patients with moderate to severe mitral regurgitation at least had a further echocardiogram. And those patients that had severe MR at baseline were then further divided into those that had either persistent, at least moderate to severe mitral regurgitation, or those in whom the mitral regurgitation had responded to medical therapy. And they were then followed up from that 9-month landmark period. And I want you to note that the mean age of these patients was 10 years younger than in the CINCH-FMR registry. Now, it won't surprise you that those people in whom the FMR went away did better over the long term. That is probably expected. But look, if we overlay the CINCH-FMR data, it looks very promising. So there's more work to be done. And it'll be of huge interest to see how this develops. In terms of heart failure hospitalization, it is parallel with contemporary data from other studies. The challenge with the CINCH registry is that, of course, it includes 3 groups of patients. It includes patients with dilated left ventricles that would be more fitting for MITRA-FR. It includes patients with less dilated ventricles, perhaps more fitting with COAPT. And it also includes a cohort of people who don't have severe left ventricular systolic dysfunction who might fit the bill for atrial secondary MR. So as the data accrue, we maybe need to start looking at these 3 groups slightly differently, because it may well be that this device not only benefits people with so-called disproportionate MR, but also those people with proportionate MR, and also people who have atrial secondary mitral regurgitation. So as with any observational cohort study, there are limitations. There's obviously a survival bias. So I'm going to put my hands right up and point that out, make sure that everybody knows we're aware of this. There are also problems, of course, with real-world data collection, which we're all aware of, variability in data availability at each follow-up time period, which is why the sample size needs to be relatively big and to continue to grow. There's also pragmatic MR severity assessment. We wanted this to be pragmatic and related to day-to-day care. Of course, that is based on site interpretation. And as I've suggested, this is interim data. Patient enrollment, follow-up, and collection are ongoing. But ladies and gentlemen, around the world, the CINCH registry is the first post-market cohort study of patients treated with the Carillon device in a real-world setting. And the data to date suggests that the Carillon device is safe. improves symptoms, reduces mitral regurgitation, and is associated with clinical stability. And we know we need prospective trials, and we've already heard about the Empower study. And I hope to see many of you at upcoming trial meetings, and perhaps even in the cath lab when we start really to ramp up recruitment and implant. Thank you ever so much.
Oh, great presentation, very thought-provoking and outstanding. Do you have any reactions, Dr. Leon, on this data?
Yeah, listening to this is for me personally very interesting, and I've always felt it's nice to have the definitive landmark randomized trial, but that's not the way things work usually. No. And it usually is the totality of data which is important, and accumulating data from different sources. And I'm someone who does believe in real-world, real-time data with all of its drawbacks in terms of adding to that totality of information. And you're looking for trends and tendencies. And what Klaus is helping me to better understand is, as a non-heart failure physician, we have such a poor understanding of the nuances of heart failure pathophysiology and treatment. When we talk about primary or secondary MR, when we talk about HFrEF or HFpEF, we think about these very large buckets, but within these buckets, there are so many different subpopulations that we need to consider. And what I'm beginning to believe more and more is that we have to start applying our understanding of how these devices work to identify what is a target population that would be best suited for a particular device. So whether it's going to be those patients that have dilated left atria and atrial functional MR, or whether it's going to be those patients that have some degree of HFrEF and mild MR, I think we need to be exploring the different patient populations and better understanding how some of these devices can be applied. The key point you made about safety, I cannot emphasize enough. If you have a therapy that intrinsically carries significant implant risks, then it's not so easy to go into this exploratory pathway, because there is a downside that you need to respect. So I think that's important. I think the second important feature is many of the devices we use are very sophisticated. They're very artistic. They require a learning curve, and it takes only certain operators that have both the dedication and the skill to get the optimal performance. To a certain extent, and you'll excuse me for using this term, this is a dumb device. This is not a smart device. This is a device that really does not require that much in the way of artistic application. It can be applied pretty much in almost everybody, and with results that I think are going to be generalizable and is not associated with a learning curve. And, even though we tend to minimize that, that is extremely important as you begin to disseminate a device into the practicing public.
No, wonderful. Just one quick question. Do you have echo data on these patients to try to understand the remodeling and the annular function and things like that would be of interest? Yes,
absolutely. The echo data will be collected over the course of time and then will be analyzed in a blinded way in order to establish how the remodeling is happening in different subgroups of patients. And as Marty hinted, it's incredibly difficult to do this in a randomized controlled trial, because you've got a selected subgroup of patients that you've pre-chosen, whereas in a registry of this type, you can look at populations, subgroups of patients, and decide, well, where did it work less well, and that then allows you to guide future trials and form a foundation, including sample size, recruitment rates, etc.
Wonderful. Thank you again for your great work. We are now going to show a case, recorded case with Dr. Murat Yildiz from Turkey, and we are
from Germany.
Germany, I'm sorry. I'm Germany.
I'm from Germany. Hello. Nice to be here in Boston at the TCT. I'm happy that I can show you the live case in a box. And we start now. Okay. But before I want to show you the live case, I will talk about how and why did we start with the Carillon implantation. I'm from Germany, Fritzlar. It's a little town in It's a little town in Germany. It's a historical town where we have a hospital with a historical with the history, and the patients which we are seeing are born there, and their parents are born there, and so on and so on. They came to us and talk with us and say, help me here, I don't want to go anywhere. And this was our first patient in January 2019. A patient with multiple comorbidities, and we knew her well because she was 4 times in hospitalization due to NYHA4. And that's the reason why SWIR, functional mitral regurgitation, LVEF is good, optical good now. And we screened the patient and thought, what can we do? And so we see Carillon implantation. And the main criteria for this patient was to do something safe. That was the first point where we want to start with that, and that's the implantation of our first patient. After that, we developed our system because we saw that this patient was going good, and the main criteria was the clinical benefit, and we had a clinical benefit for this patient. And after the implantation 2019, the patient wasn't hospitalized due to NYHA4 anymore. And that's the patient which I want to show you now. It's from August this year. It's a female, 76 years old, NYHA class 3, with prevented action fraction and SWIR, functional mitral regurgitation. And coming to the implantation, the first step, what we are doing is we are doing a coronary angiography as we do every day. From the right arteria radialis, we knew the patients before because we did the screening. We choose a 6F Judkins catheter, and then we do a coronary angiogram. We use heparin and nitro as commonly, and then we are looking for the CS. We are looking LAO caudal for that. The next step is the access of the jugular vein. We are using ultrasound, so it's not complicated at all. Then we put in the 10F sheet. And the third step is the catheter preparation. We have a delivery catheter with this is the green one, 9F, and a multi-purpose catheter, the blue one, which is 7F. And we're putting them together as a mother and child system, so we can go smooth in the sinus coronarius together. They both have a J, so we can go align in the right atrium and then turn the catheters in the position where we suppose where the vein is. And now we are going in the right atrium, turning the catheters in the right position, and then smoothly go on with the in the coronary sinus. It was not difficult. There was a valve there, but it was easy to go then. And if we are on this position, we are going with the delivery catheter as far as safe as we can go in the sinus coronarius. Next step is the sizing of the sinus coronarius. For this, we are using the sizing catheter, waiting for a backflash, then put in the sizing catheter. And when the sizing catheter is in the delivery catheter, so it's going in now, we are doing a coronary angiogram to look where the crossing of the arteria and vein is. Sometimes it helps us to see where we can put the distal anchor in. And then we are going to do an angiogram of the vein. It's look like that. And we are going to make the measurement. So we have 3 points where we measure the vein with the distal anchor, the usable vein length, and the proximal anchor part. And it's done by a ruler, so you can do it in every cath lab on the world, everywhere. It's easy to do. For this patient, we have the measurement, and we decided to put in a distal anchor with 9 millimeters and a proximal anchor with 18 millimeters. We had a usable vein length of 12 centimeters, and we use 8 centimeter device, so we pull back 4 centimeters for this patient. Outpacking of the device, this is the handle, and it's easy to use because you don't have much. We have only 3 knobs. First one, second one, third one. First one with a black and a white arrow direction, and the other ones with the black arrow direction. Connected with the delivery catheter, it's Lure lock, and then we are going through with the device into the delivery catheter. First step slowly, and then it's easy, and we connect the handle here by turning the first knob in black arrow direction. That's the deployment of the distal anchor. Only turning the black in black arrow direction the first knob, and that puts out the distal anchor slowly. This way, it's going out slowly. It's a little bit too far, but it's no problem. We can pull it down slowly, and in this case we did it too. Pull it down slowly. Now the anchor is out here. Not yet, it is out. And then we are going to lock the anchor by turning the first knob in the white arrow direction. That pushes the delivery catheter into the anchor, and this part is going over the diamond shape, and the anchor is locked now. Next step is we're looking for the coronary artery. If you have some compression on the arterial, it was not so we can go for the next step. And that's first knob, black arrow direction, without pulling and pushing, only to be sure that the delivery catheter is going down to the next trim tube of the next anchor, and it's now there. And then we stop. Okay. And what we are now doing is pulling. Left hand on the delivery catheter, right hand on the handle, and pulling by heartbeat, slowly the device out. And what we want is to reach with the crim tube this mark on the monitor. So now we have CINCH 4 centimeters. Keeping that point, we are doing a coronariogram. Sorry, I must go back a little bit. We're usually doing a coronariogram, and if we see some compression, it is not sphere to go back, only leaving centimeters back can solve the problem. But we hadn't any problem here. So we are going for the next step, and that is to lock the proximal anchor with the next knob. That's the second knob in black arrow direction. And now the pusher sheet is pushing our anchor over the lock here. At least it is locked, it is in the right position, and what we are looking now for the coronary arteries left and right. Is there some compression or is there not? There was no compression, and at least we can put out the handle. That's a safety knob. The last third knob, we have to turn it in the right, in the black arrow direction, and that disconnects the system, and the device is in the vein now. And these are the results of this patient 1 day after therapy. The patient is well. And these are the single center results which we have done. We have done 85 patients since January 2019. Main age was 81. We have more female, and we had a lot of HFpEF patients. The main implantation time was less than an hour. We had done the first 3 patients in general anesthetic and the 82 patients in anesthetic sedation. 2 patients failed because of the coronary sinus anatomy. 3 patients had an injury of the coronary sinus, which where we stopped the implantation, and then we did a second implantation weeks later, and that was then without problems. Overall, we had no MACE on our patients. We see 74 patients regularly in our center. 72 patients are well documented, and further no complications has seen. 3 patients had need an escalation of therapy. 1 was with a LVAD, 1 with a Mitra clip after that, and 1 with a palliative therapy. In our patient group, we had an improvement of NYHA class 1 more than 49%. 4% was unchanged, and 2% worsened. And we had about 53 patients where we can look for the anti-proBNP before and after, and we can see that the levels are dropping down after the therapy. We are looking 3 weeks and 6 weeks, 6 months after the implantation. So my conclusion, we had a clinical benefit. That's the main criteria. We had a clinical benefit on our patients. There was no further therapy necessary. We had seen good results in our patients, and it was easy to do, safe therapy. So thank you.
Outstanding. This is the largest experience of Carillon from a single center, so great job. And so when you see the patients, how do you decide that which patients you select for the Carillon device versus other?
We are screening every patient with the mitral regurgitation class 2. And so after that, by the screening, we are looking for the coronary artery. We are looking for what kind of mitral regurgitation did we have there. Is it annular dilatation, or have we other failure? And depending on this risk, what risk is the intervention, what is the clinical, we are going through what we are decided to do then after that.
Is there a specific anatomy that you find responds well?
I see more patients with a HFpEF and a arterial dilatation with a functional mitral regurgitation. In our patients, we have more HFpEF patients.
Anyone from the panel, any questions for?
I'll ask a question. One of the things that people in the audience will worry about is this concept of the crossing, the compression of the circumflex artery or one of the OM vessels through the device. So let's talk very briefly about that. What is your experience in your cohort of that being a problem? And then I'll tell you about ours.
It's not so often for the first and second. When we are going to do the therapy, we are looking if we have a crossing and we can avoid to develop to put the anchor over the crossing, we are going down and use a part of the vein where we do not cross.
So you're preemptively deploying the device less distally in order to avoid the crossing.
Yeah.
One of the things that I've noticed, and it's interesting because the data from other centers show this too, it's impossible to predict whether or not you're going to get arterial compression.
No, it's impossible because it's 3D. So I don't know. At least we see it.
Yes.
We try it and see it, and we do it step by step, so we can stop when we see the compression and go a little bit back.
Yeah. So you can release the cinching slightly to allow the artery compression to.
Yeah.
But one of the things that we've noticed is that you can't often tell whether or not when you start to cinch, you pull away from or onto the artery. And no amount of 3D imaging so far has allowed me to establish in advance whether I'm going to select this patient for a Carillon or not. And that's one of the things that we just need to make sure is that people understand, is that it's impossible to tell in advance whether or not the patient is going to have a problem with circumflex compression. And I think, therefore, you shouldn't deselect before having a go.
One other question for you is there any delayed risk? Because this is also a common question that people ask, that, once you release the device, is the coronary going to be, or you have seen what you are supposed to see at the time?
That's a really insightful question. The first thing is often because you've still got the device connected to your catheter, when you release it, there is usually a rotation of the mitral annulus that occurs, which does not, in my experience, ever lead to worsening compression. So what you see when you have locked your proximal anchor, that's what you get. But interestingly enough, and I don't want to mislead people, but often if you see a small amount of compression, so 10 or 20% of the artery, that, in my experience, remodels very, very well.
We use nitro.
So we usually use a bit of nitro, and then we wait. And we've now had 3 or 4 cases where we've decided that in the patient's interest, a small compression in this patient whose problem is heart failure and not coronary disease is something we would be prepared to accept. And actually, if you go back 3 or 6 months later, the artery has remodeled and you can barely see where you were. So I think this is the major concern of inexperienced implanters and inexperienced centers, but it's really a minor problem in the vast majority of patients.
It is very interesting that we're looking at very different populations again. This is this is a population of more severe MR, more preserved LV function, probably more dilated left atria. I'm assuming a high frequency of atrial fibrillation in these patients.
85%, something like that.
So this is, again, it's very different than your experience, Klaus, in your registry, in terms of the patient population, yet you're seeing significant reduction in MR and improvement in symptoms in these patients. And we're just beginning to get our arms around this interesting syndrome of AF-associated atrial functional MR. So we're trying to understand how to best manage these patients, and this very likely is it'll be a subpopulation in Empower, but we're not really targeting that population here.
Correct. We are not, because we are still using a little bit of reduced EF and dilated ventricle. I think this leads us to the study design presentation for the Empower trial. Thank you very much again, and my pleasure to present the trial design for the Empower trial. This is a as we have already learned, that we want to do a trial as a first or early interventional treatment for functional MR in patients with heart failure. I want to say that we want to treat the patients with heart failure who may or may not have mild, moderate, or severe MR. So the target population is heart failure patient population, and then we'll stratify them according to the MR. We want to do a trial which is blinded, sham controlled, with a core lab that is independent data adjudication. So this is a very well-designed, high scientific standard clinical trial. Patient population is a wide patient population that any degree of FMR we want to treat with a dilated ventricle. As you saw that in the reduced FMR trial, when we tried to analyze that which patient benefited the most, this was the mostly benefited patient. So this is the population that we are treating in this particular trial. I'll go over the medical management therapy, but it is simple, and the patients will have a simple sequential therapy on the protocol. So if you needed to do something differently, you can also do it in the protocol. Why we have selected this population? So as you have seen from Dr. Deep's presentation, that if you take the 77 patients with reduced FMR who met the criteria for the EMPOWER trial, or the EMPOWER trial was designed based on this, to say that the device was in 50 patients, no device in 27 patients, mitral regurgitation reduced, the forward stroke volume increased, LV and diastolic volume decreased, ejection fraction got better, mortality, of course, a very, very small study, but in a favorable way. Heart failure, hospitalization favorable, KCCQ was favorable, one class improvement in the NYHA class, or more than one class improvement in the NYHA class, all were favorable in this small but very well conducted CEC adjudicated as well as core lab adjudicated data. So this is where we designed the trial EMPOWER based on this very important information. What does the trial look like? So trial is going to randomize 300 patients in 75 sites. First, we'll randomize 150 patients, 75 in each group, one-to-one randomization, medical treatment versus Carillon device. And then we'll do an interim analysis, and then we'll complete the rest of the trial with 150 patients total in each group. The primary endpoint is with the win ratio, with all-cause mortality, alternative therapy, meaning heart transplant or LVAD. So this is the surgical alternative therapy. And then the second group is the alternative therapy that is percutaneous or mitral valve surgery or TEER procedure. And then the heart failure rehospitalization, then the KCCQ, and then the 6-minute walk. We have several secondary endpoints. As you have seen, the change in the regurgitant volume, change in the heart failure hospitalization, 6-minute walk, change in the LV and systolic volume index, and diastolic volume index, KCCQ, NYHA class, cardiovascular death and heart failure, and all-cause mortality. All of these different exploratory secondary endpoints are powered in this particular trial. Study recruitment is the most important thing for us because we want to complete this trial sooner rather than later. And we have tried to make this trial easy to recruit. So the patients should come from the heart failure clinic, that's what we feel, and from the general cardiology clinic. There is no currently competing trial for this patient population. So if the patients are having heart failure and they have any degree of mitral regurgitation, you can offer this therapy to them. Only thing is that the patient have to be on a stable heart failure medication for 30 days. The TEE exam is done. We do not really need a CT scan or the TEE examination. So this is unique for this patient population. LV ejection fraction has to be less than 50%, and end diastolic diameter has to be more than 60, and end systolic diameter has to be less than 70. So this is an important LV dimension criteria. So just remember that LV has to be somewhat dilated, but not overly dilated. And any degree of FMR is allowed in the trial. So what are the key features? Again, to reiterate, that you can enroll large number of patients at the earlier disease state of FMR in heart failure patients, so any degree of MR. The procedure time, as you have seen, is very small. So this is a simple, fast procedure with conscious sedation, no need for TEE. Sham is very easy because once you put the coronary sinus catheter, then you randomize the patient depending on the sinus size and the coronary artery. So this is a simple, easy to enroll and to do a sham procedure, because if you randomize to medical arm, you just remove the catheter and you are done. Otherwise, it takes another 10-15 minutes to put the device. It's a 10 French system, so it's not large. Its wide range of mitral anatomy is allowed. It cannot be primary mitral regurgitation, but any other kind of mitral regurgitation, functional mitral regurgitation is allowed. And there is no mitral stenosis that we see with this therapy. So all the alternative therapies, including TEER, is possible. The shadowing from the ring is also minimal. So again, you can see the leaflets very well if you want to do TEER procedure. So this is and in the trial, as you saw, the endpoint includes percutaneous mitral therapies. So after 3 or 6 months of therapy, if the patients are not doing well, you can go ahead and do the mitral therapy. So it does not prevent future mitral therapies. So I'll end there, and maybe we can open it up to the discussions to say that how we can enroll these patients faster and quicker in the trial that we have already just launched. And we have 26 sites which are active, and we are screening actively. We have already enrolled several patients, and several are in the queue to be implanted at this point in time. Any questions from or final remarks while we finish?
No, first, I think people should appreciate this is really a unique trial design. And it has several features which I think are both different, and I mean, ultimately they may also be challenging. The strength of the study, again, as Samir pointed out in the beginning, is this is a sham-controlled study. It's the highest level of scientific rigor, and sham-controlled studies are difficult to do. So, we've experienced some disappointment in sham-controlled studies, but this device allows you to do a sham-controlled study. So any difference that's observed, as long as we can maintain the blind, is really going to be very meaningful, and people should understand that. There may be some, I mean, you already have an approved indication for functional MR, severe MR with coapt, so I'm imagining that some of the patients that might have come here that are coapt-like may end up getting MitraClip earlier, I would imagine, in many centers. So it may be that you are going to skew the population to lesser degrees of MR.
And we are stratifying the randomization according to the mitral regurgitation severity, so that should help. Any final remarks, Klaus?
No, I think this has been an amazing session. I've learned a lot. It's been a real privilege to be involved with it. I think the Empower study will give us information about an additional group of patients with mitral regurgitation and heart failure symptoms that we're currently not treating, and it'll help us understand treating earlier and the outcomes and the risks and benefits of doing so.
Thank you very much, everybody, for coming, and we will conclude the session at this time. Thank you.